Good afternoon. I'd like to call the committee to order. Let the record show that we have a quorum present, and I want to thank all those who decided to return after we were unable to meet on Friday. This afternoon, we're continuing our hearings on the ensuring quality health care and the health of population, and we have invited Mr. Mervyn Connolly as the Director of the Department of the Health Regulatory Services, and Ms. Lyra Lawson Joseph, the Registrar of the Health Practice Commission. Thank you all for coming. When you answer the first question, just identify who you are and what your responsibility, just for the record. Okay, well, I guess I'll start things off by, and you're concerned with two areas, the Health Insurance Commission and the Department of Health Regulatory Services. So I guess we'll start with the Department of Health Regulatory Services. And you have been given the full report, right?
Yes, I have.
Okay. And you will notice in the recommendation side that you have been identified as responsibility for the implementation of several of the recommendations, starting with recommendation 3, 4, 5, 6. You're part of those recommendations. So those are the recommendations that we'll kind of concentrate on. On the health regulatory side, one of the things that we're a little bit concerned about is how the Department of Health Regulatory Services license facilities. The facility license falls under that as well, right?
That's correct.
Okay. What is the current status of that, and how do you monitor the standards? So if you could just talk to us a little bit about that, and whether how do you maintain or assure that the standards that you have been that you have granted the licensing facility for are maintained? Do you do routine inspections, unscheduled inspections? What's the position, the facility's license? Is it an annual licensure? That kind of thing, and then I'll have quite a few more questions. We'll follow up.
Thank you very much, Mr. Chairman. I am Mervyn Connolly, the Director of the Department of Health Regulatory Services and the Superintendent of Health Insurance. Perhaps it may be useful for us to just have a little background on the department itself, and then we can, see exactly, who'll be responding to the questions. So, just around mid-2008, the Health Insurance Commission was merged with the Health Practice Commission to form the Department of Health Regulatory Services. At the time, the decision was, as I understood it, was purely from an administrative position, meaning that the two units were fairly small, and it was felt by central government that if the two departments came together, they could be managed more effectively and efficiently. So at the time, I was already wearing the hat as Superintendent of Health Insurance. But there's also another statutory position, the Registrar, which is obviously very key, in regards to administering and supporting the Health Practice Commission Board and the councils. So Ms. Josephs is the Registrar. So in the department itself, on a day-to-day basis, as the head of department and superintendent, I really don't have a lot of day-to-day interactions with the councils and the Health Practice Commission Board. I certainly have a lot of interactions with the Health Insurance Commission Board, and obviously under the health insurance law, the superintendent is responsible for administering the health insurance law and regulations. The registrar doesn't necessarily have a similar function as the superintendent. The registrar provides more of a support, meaning from the point of view of managing the minutes, making sure that all of the decisions that are taken by the councils and the board are properly documented and recorded. And certainly the registrar is also responsible for entering the names of those persons who have met the criteria and able to be registered on the register. So our interaction then in regards to the department with the councils and the board is to provide administrative support and obviously technical advice to them on various matters. So with that in mind, then the questions in regards to the maintenance of the standards. Again, the standards, we actually employed the first health insurance inspector in 2009. And actually it was one of the first duties that I undertook as the head of the department to ensure that that post was first of all established in the budget and that we had sufficient funding to certainly cover that key post, meaning the health practice and facilities inspector. So right around 2009, going into 2010, we started what we consider to be a public education process where we worked with the stakeholders, mainly the healthcare providers and healthcare facilities, to really give them as much information as we possibly could in regards to the standards that actually had been on the books for perhaps 2-3 years prior to that time. So in 2010 is when we really immersed ourselves into trying to pursue the inspection of healthcare facilities so that they would obviously then be certified and registered as healthcare facilities. So, Mr. Chairman, when you look at that, we have a little bit more than 5 years experience since the first inspector was appointed. And I think basically what is done, we do have a schedule that has been set up for all of the healthcare facilities. And as it is now, the Health Practice Commission Board made a decision that you can get, your license can actually be for 1 year, 2 years, or 3 years, depending on your history and depending on how compliant you've been, over the preceding period. So the health facilities inspector is really required to maintain that schedule. And then when an inspection is conducted, obviously we apply the standards for that facility. And a report is then provided to the Health Practice Commission Board. And the Health Practice Commission Board would make a decision in regards to the whole issuing of the license for that particular facility.
Do you rely at all on what seems to be becoming very popular is, I'm not sure I got all the acronyms, but this joint accreditation, hospitals joint accreditation. Do you put a lot of reliance in that, or you do your own?
No, I think we certainly rely on the Joint Commission standards. Again, that is very robust. It's tested. And basically, if a facility can prove, that they have that type of, met that type of standard, then obviously that is significant. Now, there may be 1 or 2 variations in regards to the local environment, but by and large, that is what has been used to set the benchmarking and the standards.
But if a facility claims to have that, do you verify that with the supervising authority, and you still do your inspections?
We still conduct our inspections.
Talking a little bit about the professionals themselves, we have had some some evidence that there seems to be a difficulty in getting the ministry and the political arm of government to make the necessary changes to improve the standards in the raising the levels of the professional standards. Is that so, or?
Well, I think from where I sit, what I see is that obviously there are some facilities which came out in the report that are not currently registered, and certainly they could have been considered healthcare facilities. The intent was that they were going to modify the existing standards to meet those facilities, and that hasn't happened, unfortunately, because I think, in our opinion, certainly those facilities should be inspected. But I know that certainly there is some work in progress to have those standards revised, and certainly so that they can capture these type of fringe type healthcare facilities.
Right. But one of the statements contained in the document on page 16, section 44, the Auditor General says, in relation to the government's capacity for exercising its authority and effectively carrying out its roles and responsibilities, the most common concern expressed by the public as well as the private sector executives and professionals we interviewed was about perceived serious capacity shortages in the ministry, the Department of Health Regulatory Services, and the HSA. Have you been given any support to improve your facility, your own department, i.e., adding more staff, so in order for you to be able to cope with the workload that you have? Because it seems to me that there's not a lot of people there now.
Yes, Mr. Chairman, I think that's an accurate observation in regards to our staffing levels. But having said that, clearly, when we're preparing our annual budget, there are parameters and constraints, and we're pretty much given what the target number is actually before we even submit the budget documents. And I can tell you we've been through some very lean years where actually, the budget was extremely tight. Having said that, we obviously work within those budgetary constraints in regards to performing our duties at the department level with the resources that we're provided. The bottom line is that yes, we would certainly welcome additional staff, both from the Health Practice Commission side and from the Health Insurance Commission. But clearly, with the type of budgetary constraints that we've been, faced with over the last several years, it made it extremely difficult for us to achieve that. Having said that, I have now been provided with an additional post in this annual budget, and hopefully we're now in the process of, hopefully getting that position filled.
Well, it's a matter of priorities, because it's safe to say, although the budget office is here this afternoon, that year on year there hasn't been a reduction in expenditure. Each year, while they give you the parameters, they have spent more money each year, at least what the documents they bring down here, year on year. So we understand that they're the competing forces, but we also believe that this is a very important area in government and has a serious impact on the country having the confidence that you have the resources to do your job. If I could just ask a couple of questions, you want to ask some questions on that? Okay, I am going to move on to the health insurance now, if you want to.
Mr. Chairman, through you, in terms of the relationship with those 4 professional bodies that come under your umbrella, in terms of the registration and licensing of health professionals. We had some testimony last week or a week before from members of I think it was the Medical and Dental Council, regarding the professional qualifications and whether or not they were internationally acceptable or lacking in there. In terms of when you hear that type of messaging coming from your councils or your boards, can you describe what the procedures are and what the actions then flowing from that would be, i.e., would you pass it up to the ministry responsible, or would you make a determination and a recommendation then to the minister, given that one of the roles that you have is also an advisor to the Minister of Health?
Through you, Mr. Chairman, it's a very interesting question that you asked, and I'm not going to go back too far, but I think we all know that we recognize basically 7 jurisdictions. And I think what the Health Practice Commission and the councils recognize that certainly an individual who has obtained qualifications in one of those 7 jurisdictions, that is what has set the standards, so to speak. And if you're registered there, obviously, then when you come to the Cayman Islands, we would certainly want to honor that type of qualification, that type of recognition of the experience and skills that individual brings. I think where it becomes a little more of a challenge is certainly when we have individuals who, let's give an example. For example, let's say we do recognize obviously UK qualifications, but if someone comes, let's say, from one of the Eastern European countries, how do you then equate those because of currently still the European Union, that type of arrangements? I think the idea is that the councils are still wanting to ensure that those individuals meet a minimum level of standards, and that their qualifications are certainly vetted. Again, it is vetted on an individual basis, so that each individual that comes to be registered, their credentials and their qualifications, experience are certainly vetted based on what they have and what they have. But if you don't mind, Mr. Chairman, for additional information, if I could ask the registrar perhaps to provide additional information.
Sure.
Registrar for the Health Practice Councils of the Cayman Islands. So I sit on the Health Practice Commission Board and the 4 councils. My responsibility is really to ensure that the action decisions and that council take on are guided through the health practice legislation and records of decisions maintained in compliance, and everything has to be in compliance with the Health Practice Law 2013, because that's where we are now. I'm also a key responsibility for me is verification of all documents that come in for every single practitioner which you register in this country. So sometimes it means that I have to make a phone call to even a professional reference or a personal reference. It means that I have to go to a council, whether by email, verification of authenticity of the notary public. So every document that comes in before it's presented to council, they're vetted according to what's in the health practice law. So if it doesn't get past us, it does not get to the council. So we really do, because we have people that come with a Jamaican registration, but you were trained in Spain or another country. One of the things, your first medical degree is recognized by Caribbean Medical Association. And you can do an examination through them and gain Jamaican registration. But your specialty qualifications from those countries are not recognized, although it's listed on your qualifications from Jamaica. It is not recognized here. It is only recognized within the 7 territories that we know are authentic. So you'll come from Spain with a registration in Jamaica and they put dermatology on it. You will not be valid to practice dermatology in this country. You'll have to physically get it from you'd have to do some training in Jamaica at the University of the West Indies, which is where they recognize a specialty in Jamaica, only University of the West Indies. Or you'd have to get it from the USA or the UK. But the specialty registration is not license eligible for the specialty registration, but you must have a fellow, not a membership, but a fellowship within these organizations. Because I can be a member of anything, but I need to sit an exam before my peers and be examined, and this is a valid document for us. Oftentimes, a lot of these countries are going to electronic systems, so we get the documents from them, but we still go back to the databases to check and validate them from the databases themselves, because the database will tell you whether they're medical doctor, specialized in dermatology, subspecialty in pediatrics. So we still go back again, double, triple confirmation of what we have to present before council is authentic documents.
Mr. Chairman, through you then to Mrs. Joseph, in terms then of, we've heard of the rigor that occurs. Mm-hmm. How often is that that criteria reviewed in terms of the 7 jurisdictions? Is it keeping up with best practice? Those sorts of things. And when was the last review?
Hello, through Mr. Chairman. The most recent review was of the Medical Dental Council guidelines, because they wanted to ensure that the individual working here are not just medically trained, first degree with limited experience and no specialty qualification, because the people of Cayman deserve more, they deserve quality, they deserve the best practice ever. We have a high doctor per capita in this country, so what we want to provide is more than basic training, okay? That's what we want. So it was reviewed recently, and they upgraded their guidelines to meet international standard, and that is key for them. And it's frequently updated. The Nursing Council has upgraded their standards. It's incorporated the Cayman Islands nursing group that's here at the University College of the West Indies, the bachelor's degree program. And it also takes into consideration as well, right now they're currently updating all their code of conduct, their code of ethics, sorry. So all those documents are vetted and compared to ICN standards. So they are updating that. And of course, you know that the Allied Council has a vast amount of professions. So what they do per profession, they update them accordingly. So this year you might have 500 for massage therapists. They might want 500 plus 2. So they're constantly updating to meet international standard. And of course, they also decide, am I going to take the US because their medical system is being a little bit lax? Am I going to keep Jamaica because they have not updated their law since 19 whatever? Am I going to keep the Jamaica Pharmacy Association? Am I going to use the Bermuda Pharmacy Association to compare to see what they're doing? So they do use regional comparison and international comparison to ensure. Australia is a great example they have used, and the forward thinking of the Australian process, they've used that, and the Medical Dental Council guide their practice. So it's a constant update, and they do it to ensure our public is getting the best care possible.
Yeah, sometime last year, I think it was in the, could have been in the February session, the government accepted a motion to upgrade certain of those guidelines to regulations. I can remember specifically part of that was the standard English test. Correct. Has that been upgraded to regulations yet, or is it still guideline?
Well, it's not, certainly may not be in regulations as yet, but the councils are definitely utilizing that standard in regards to the proficiency in English. Yeah.
Is the council utilizing it as a guideline, which is kind of quasi-enforceable, not enforceable, whereas a regulation carries the authority of law, and therefore not only is it enforceable, but there are usually penalties if you don't do it.
Yes.
So is there any explanation for the delay in getting it done?
Mr. Chairman, I don't know if I have a response to the delay in regards to getting it in regulations, but certainly the guidelines are there, and my understanding is that the council is utilizing the guidelines.
My concern would be that if they challenge guidelines in court versus regulations, the council might be in some difficulty.
That would be correct, sir.
Mr. Chairman, through you then, in terms of the public policy kind of viewpoint, and this is basically to have a statement from the HPC to the wider Caymanian audience. Based on your professional qualifications and viewpoints, the law covers that international standard, and the people of the Cayman Islands can be well assured that doctors practicing in both public and private medical facilities have all met that standard.
Sir Chair, yes, absolutely. Every single practitioner that walk through our doors, they'll come in 3, 4. The process that we use for vetting the applications, we have the guidelines, as you know, that it's on the website. They will come in with their documentation, and we have a checklist. If they don't meet one of the checklists, we circle it and we send it back. They will come in 10, 15 times if they have to, just so they will have to comply. Once they meet our standards and according to the health practice law and what we recognize, then they're sent to council. And remember now, they're only license eligible. It's not a right, and it's not a guarantee. They're only eligible for the council to vet to see if they deserve to have that designation, professional designation in the country. So when it goes to council, they also do their own vetting on it. Sometimes I might have to go back and double check something before it might be deferred and come back to the council. Or they might say it's deferred pending a document from professional reference, clarification of the certification of specialty registration. So everything go back and we're double vetted, triple vetted. And once that is done, they're granted a registration. And once that registration is provided, it doesn't mean that they go out there and take up and put up their shingles, as Ms. Gandhi would say. No, they now have to go off and access malpractice coverage with that registration document. And we do what we call a bait and switch. So once you give it to me, and we're happy that this is a valid malpractice insurance and it's good, we then provide you with the registry, with the practicing license. Now you can go out and start practicing.
So, Mr. Chairman, I think it's fair to say that we have a a very robust process and system, and certainly due diligence is conducted. I think the registrar said earlier that we just don't accept, the documents. We actually pursue to verify and confirm that those documents are really valid and legitimate documents.
What kind of monitoring goes on of the profession once they're licensed? I.e., do you look for medical audit or peer reviews in terms of their performance, or do you rely on complaints from patients for malpractice? And what is the process in dealing with patients' claim of malpractice or things that might turn up in medical audit peer review to be?
Mr. Chairman, excellent question. I think if we are really being honest, I think this is an area that we need to improve on. Certainly, I can say to you that even from the other side, I guess, of the balcony, and looking at it as a patient, and certainly I think this is an area that we're lacking. Unfortunately, we don't do that type of in-depth peer review. The council obviously makes the decision in regards to the complaints. So let's say a patient has a complaint, it would probably come to the department in the initial for us to document the complaint. The complaint is then actually taken to the council or to the Health Practice Commission board for them to actually do the vetting and make whatever decisions they deem necessary on that. So that is really not done at the department level. Unlike the Health Insurance Commission side, where the superintendent of health insurance have the authority under the law to actually go and actually investigate the complaint. And where necessary, we can issue a directive for the matter to be corrected and or other enforcement action where necessary. So we rely heavily on the councils, through the professional peer, for them to actually look at these type of complaints and obviously make decisions in regards to what action is necessary. Again, the registrar and the health practice facilities inspector would be certainly able to assist them in any investigation. But as far as what action that is determined to be suitable for that is done by the councils and or the board.
And that action is normally based on regulation?
I would want to say yes.
Mr. Chairman, through you, I'm heartened by that response in that, when we heard these things 2 weeks ago, it was a kind of a shock in terms of, thinking that there might be different levels of qualification which make certain routes to certification and registration somewhat less than others. And in terms of the weaknesses that you just accepted, are there in your role again as advisor to the minister, have these kind of areas been highlighted before, or can this committee help by highlighting some of those and putting them in our report? Because if the standard can be, or if the criteria can be raised and the vigilance robust after the process as well, tracking the malpractice suits and looking at where maybe some of these people are, the routes that are coming around, tracking statistics, i.e. is there one area that, one route that has a higher number of complaints and malpractices, because those are then things that you can take forward and really, intensify the scrutiny and the rigor, which would, allow the public to feel comforted that not only do you do it before, during, but definitely afterwards as well. I mean, has that occurred, or can this committee help in terms of highlighting some of those areas for more resources?
Through you, Mr. Chairman, I think it would be fair to say that there have been some cursory discussions, but nothing that has really been, formalized. So, again, as I said earlier, I think certainly this would be well in keeping with what the department would want to see happening in regards, again, to protecting the public and ensuring that, the quality of care that is being provided is certainly of the highest quality.
How do you manage institutional registration? And what regulatory supervision do you have over institutional registration in its current format?
Thank you, Mr. Chairman. Clearly, we do have a facility that has, obviously been given that type of recognition. From the department point of view, we have been given some guidelines in how we look at those practitioners. And again, we do vet
And those guidelines came from cabinet,
I think
from the council.
From cabinet.
So again, based on those guidelines, we ensure from the department point of view that they go through the process, and we do the due diligence to ensure that those individuals, certainly have gone through the programs, even if it's in one of the jurisdictions that is not necessarily recognized under the legislation. We do go back and ensure that those documents are certainly valid, and that they are legitimate. And again, obviously, this is something that we take strong. We feel very strongly about it, and sometimes it does cause delays in the registration of those practitioners. But based on the guidelines, we ensure that they meet those requirements.
Mr. Chairman, the individuals registered at institution on the institutional list are only allowed to work in that particular facility. They're not allowed to work anywhere else in the Cayman Islands.
Right.
They're only in
Yeah.
that facility.
And that was part of the justification of the government of the day for bringing that whole barn door which lowered the standards beyond the wildest imaginations. But the truth of the fact is now that according to their own statistics, 90+% of their patients are Caymanians. Because when we were given this thing of institutional registration, it was, well, we really don't need to have that high qualifications because they're not working on Caymanians, right? But by their own statistics, the majority of their patients are Caymanians. How do we assure and how do we explain to Caymanians the difference in the levels of registration, to give them the comfort that they have the same protections?
It's a very good question. Again, we rely on the guidelines that have been obviously approved. I can say to you again that certainly all of the practitioners there do meet those minimum requirements. And having said that, there are some of the practitioners in that particular facility do meet the qualifications and requirements from one of the other recognized jurisdictions. So,
Why it should never have been done, because it wasn't necessary. But,
so we do have, but again, and also the facilities, we also ensure that the facilities are certainly inspected. So even though they present themselves as having met JCI accreditation, we certainly then went back and utilize our standards for the inspection of the healthcare facilities.
One of the disturbing pieces of evidence that we got was, and we have the written evidence to support, we have a situation where there's been communications from the Medical and Dental Council, from the Medical and Dental Society, going back until the 27th of November 2013, the 18th of February 2014, 7th of September 2015, 10th of September 2015, basically asking for the same consideration of matters. And the evidence put to us was that none of this has even been responded to as being received. And that is very troubling to this committee, because having reviewed what they're asking for, the things that they're asking for are not unreasonable, and certainly from where I sit, being a professional hat myself, I would support and I agree with many of the recommendations and changes that they're having with. And this seems to be the common thread at the Ministry of Health level, both on the health practice side of it and on the Health Insurance Commission side of it. And I know it's it's unfair to ask you why it hasn't happened, because it's not within your purview. But I just want to the question I want to ask you: were you aware that this type of correspondence was being written?
I think it's fair to say that yes, yes, we are aware. Yes,
because you would have no knowledge if there was a response or not, unless it was copied to you. And absolutely. I don't want to ask you that question. Okay. Shifting now to the, and we may cross back and forth as we go forward, but shifting now to the health insurance side of it, again, it seems to be that the biggest complaint from the private sector and the public sector is the health insurance component of the healthcare field. Is this again because of a breakdown in communication, right, between your office and the ministry, or between the Health Insurance Commission itself? One of the things that troubles me from a strictly governance point of view, right, is that there seems to be this belief and this practice in the ministry that if we have somebody sitting on the board, there is no need for formal communications which clearly delineate, separate, and hold accountable the agencies that are responsible. And this is whole gray area that because somebody from the ministry sits on the board, then they take back, I would assume, their interpretation of what was discussed and whether there's any need to implement that or not. Is there a formal means of communicating from the Health Insurance Commission to the ministry and the minister?
Thank you very much, Mr. Chairman. I think it's fair to say that the system in regards to the funding of healthcare in the Cayman Islands is it's a fairly complex one, in that you have obviously commercial insurers who are providing health insurance products, and while the health insurance regulations and the health insurance law does provide some parameters, clearly, because we have such first of all, a large number of approved insurers who are selling health insurance products, and a large number of health insurance products. So what the health insurance regulations or have really set is more or less the parameters around the provision of the standard health insurance contract, which is actually the basic plan. What the legislation does require, though, that all of the supplemental plans does have in it the benefits of the standard health insurance contract. In other words, you cannot sell a health insurance plan unless it has embedded in it the components of the standard health insurance contract. But having said that, it's clear, though, that from where I sit, I see we have four major stakeholders. So we have the healthcare providers, who obviously provides, the treatment and services to patients who have health insurance cover. We have the insurance companies, which has to be licensed by CIMA, that is the Cayman Islands Monetary Authority, and approved by the Health Insurance Commission to sell health insurance products. And then we have employers who are required to provide health insurance for their employees. And then the fourth major stakeholder from the superintendent's point of view is insured persons. So depending on where you are as a stakeholder, obviously you'll see things a little bit differently. So let's go back then to the healthcare providers and the insurers. And it's fair to say that the approved insurers and health insurance companies are required to meet very stringent requirements to be able to sell health insurance products. We conduct at least on an annual basis on-site inspections and audits of their records. And on a monthly basis, we receive significant amount of information from them. So they are obviously, in my opinion, they are closely monitored. But it's clear to say that they have, their objective is to, at the end of the day, is to ensure that the premiums that they're collecting is not outstripping the claims that they receive from healthcare providers.
Their job is to ensure that the premiums outstrip the claims. I think you indicated the other way around.
All right. Yeah. So they have their premiums, but they want to make sure that the claims don't erode
Don't get more. Yeah.
Yeah.
Right.
So from that point of view, obviously, they apply a number of I guess you could call it a number of initiatives to ensure that at the end of the day that they are obviously sustainable, meaning they're in the black, so to speak. And I don't think we can fault them for that. Where I have a problem as superintendent of health insurance is where an insured person has a plan of benefits which clearly meets the particular, let's say, episode of illness, and where those claims are denied with little or no justification. And in that instance, where we obviously have that information, we will pursue that insurer to make sure that they do accept those claims from that healthcare provider. Now, in the processing of making sure that the patient receives the care or treatment or service that is required, a lot of insurers also apply something called pre-certification, or pre-cert, as some people refer to it as. And the whole aspect of pre-certification is really not covered in the regulations. So the way it operates now is that a healthcare provider can submit a claim, and the insurance company can say, we need pre-cert on that. And obviously this would be in elective cases. In an emergency situation, it is really not required until after the treatment is provided. But certainly in elective cases, they usually require a pre-cert. And there's varying standards that is applied to this pre-certification. And I think this really frustrates the healthcare providers, meaning that an insurance company, a health insurance company, can use the pre-cert process to really, one, not necessarily deny the claim, but delay the claim. And when they do that, it means then that they're questioning the attending physician in regards to whether the care is medically necessary or not. And the feedback I've gotten from the healthcare providers is that quite often they feel that the insurance companies are utilizing either entities that are outside their office, or if they're employing those persons who are looking at these type of pre-certs, they're really not qualified to the level of a physician. So you have a non-physician who is questioning, a physician about whether a treatment or a service is medically necessary. So that is something that I see happening, certainly in the business. And the commission is certainly now looking at that. And again, we're not quick to want to issue or introduce regulations where it may not be deemed necessary. But clearly where you have repeat complaints, about the same matter, then it's clear that, if the market itself cannot resolve it, then we'll have no alternative but to introduce some type of regulation to address the matter. If I could, though, on the other side, now looking at the healthcare providers, obviously they need to make money. It's important that they also make money, not only for their overheads, but also so that they can continue to practice. And I believe that one of the vexing things from the healthcare providers that has certainly been brought to my attention is that they feel somehow constrained by the standard health insurance fees. And it is true that the standard health insurance fees are set to really try and establish some level of reasonableness in regards to the fees that have to be paid by insured persons and obviously the health insurance companies. But in the legislation, there's nothing there that prevents a healthcare provider from charging fees that exceed the standard health insurance fees. And while we have, based on the last report, the actuarial report that we received, approximately 4 to 5% of the current healthcare providers are utilizing the standard health insurance fees. And certainly, in many instances, in my interaction with healthcare providers, obviously they would prefer to have fees that are higher than the current level of shift fees. But the feedback I get from not all, but certainly a good percentage, is that, we can work with these fees. The problem is that we need to be paid on a timely manner. So if the insurer is taking an inordinate amount of time to process the claim, that is where I think the problem arises. So we have two issues depending on which side of the balcony you're sitting on, where the healthcare providers are feeling that, we need to be, first of all, the fees should be increased. And secondly, we need to ensure that the timeliness of getting their payments when they submit a claim, that is improved. And then on the other hand, on the other side of the balcony, we have the insurers who are saying, well, we have to make sure that there's no abuses and there's not, that type of thing going on. So, from the superintendent's perspective, certainly, again, we make decisions based on what the legislation empowers us to do. And again, I feel that, with the resources I have available, that we try our very best to ensure that all complaints, whether it's coming from an insured person, a healthcare provider, an insurer, or an employer, that we deal with those complaints, in an expeditious manner and certainly fair and consistent.
Isn't it fair to say that when the insurance companies are having their premiums calculated actuarially, they use the health insurance fees as a huge component of that, and really and truly, the actuary should not and not normally take into consideration deny, delay, and refusal to pay. Their premium is based on a person claiming that based on the incidents and the demographics and everything else and being paid those fees.
Yes.
What is stopping the government from putting in place legislation that requires real-time authorization, verification, followed by authorization, followed by payment within 24 hours?
Mr. Chairman, to answer that question, clearly we recognize the need for an electronic verification system. Again, it is, to me, it is one of those facilities in this day and age, because I think, as I've heard you say it in previous forums, the technology is there.
Been there from 1990?
Exactly. And I think going back to 2012, 13, and I don't want to rehash too much of this, but clearly I think, the government recognized that, yes, this is something that is definitely needed. Unfortunately, again, we know what happened with that particular initiative. And it's really unfortunate, because the need is, I can't stress how much we need such a system. It would reduce, I believe, the number of complaints that we receive from healthcare practitioners pretty much, I would say, by 60 to 70%, if not more. It certainly would also help the insured persons. So when you're presenting yourself to a healthcare provider, you will know exactly what your health insurance is covering, and you will know what is required of you at the time that you are there receiving your treatment. So unfortunately, again, the government recognized that, yes, that is definitely something that is very necessary. And one of the things that we need to do now...
You mean your department and the Health Insurance Commission recognizes that? Because I can't agree that the government does, because I have in my hand a amendment to the health insurance law that's coming before Parliament on the 22nd of February, and it's not included in that.
Well,
So,
to make it absolutely, yes, it's certainly not
Yeah.
covered inside there. But certainly it's a recognized need for the entire industry. And I believe that if we were able to implement that, it would be so much better for all of our stakeholders.
well, they might have to face such an amendment, because it wouldn't be unreasonable, in my view, to include electronic real-time verification and authorization as a condition of the certificate that this legislation is proposing that the Health Insurance Commission would grant, and that being one of the conditions under which the licensure, this thing could be withheld and or withdrawn if it wasn't done.
Well, Mr. Chairman, just a quick response on that. I think, again, we spoke earlier about the complexity of, the system that we're obviously, operating in. And I think one of the things that perhaps makes it a challenge is that we have 9 approved insurers who are selling a myriad of different plans. So it would mean that any system that we would have mandated, that the approved
But there's
insurers...
no need for us to mandate a system for them. They must produce a system.
Well, I mean, mandating
I might go to the hospital and there are 9 swipe card machines in front of me, but each insurance company would have to produce their own. Or an alternative would be to have somebody like the HSA provide the service for a fee to all insurance companies.
I think the latter would probably be better if we were able to pursue that.
I agree with you, but we have to make it a requirement for each individual licensed insurer, and as a part of their licensing process and the continued certificate that they have to provide it. How they provide it is up to them to go and negotiate it.
Mr. Chairman?
One of the things that I believe is not only driving up cost, but driving up frustrations, is the complications that we put on this, and we keep talking about how it's such a difficult thing to do. If we had a simple system that didn't allow pre-certification, didn't allow pre-existing conditions. You didn't have to have 995 CPT codes, but you were either in a hospital or you wasn't, right? It would probably, in the end, reduce the cost of healthcare because of all the administration that is required to meet all of these complications that they insist on installing in the system to allow deny. When they can no longer deny, then they delay, right? And when they delay, then they can't delay no more. They finally write a check that might clear, come from some foreign company, and it takes 2 months to clear.
Mr. Chair, if I could, no, there are one or two current approved insurers who do have a system that they're using, but again, it is not robust enough that where we have widespread usage of that. So I totally agree with you that anything we could do to certainly get that system introduced would certainly be helpful for the entire marketplace, the health insurance marketplace.
One of the trends that I have noticed in the amendments to the health insurance legislation is they seem to always be in favor of the insurer, right? In terms of what I see coming down here, and but I've been here now nearly 8 years since this law has been in place, is that the majority, including this one, right? Although you will get a little fee and you'll get some extra work out of it and having to issue certificates and monitor it, right? It's just another way of them being able to say they got some changes that benefits them, which is likely to lead to increased premiums again,
Well, Mr. Chairman, I don't think they're actually welcoming these amendments because, again, as you said, there are a number of conditions which, again, they're currently being required, but no, it'll be now mandated.
And then they're probably more trouble about the individual coverage than they are about anything else.
And again, that is an essential, Mr. Chairman.
But in truth and in fact is, because they have pre-certification, because they have pre-existing conditions, nobody offers group health. What they're offering is individual coverage discounted on number of persons. Because true group health requires none of that. You take the demographic and you set the premium based on, and in most of, there's hardly, I can't think of any demographic here other than the indigents and the over 60s and up that you would have more people in the group sick than healthy. In most workplaces, by the majority of the people in the workplace are healthy and have very few claims between that age group of 25 to 40, 50, 55.
Mr. Chairman, just one matter. Certainly, the current legislation doesn't. The approved insurers are not allowed to underwrite for the standard health insurance contract. So, except where permitted by the Health Insurance Commission. So, for the standard health insurance contract, again, as was actually done up until 2013, where they could use the simplest of medical, conditions to deny coverage. Let's use, for example, diabetes or hypertension. The approved insurers are no longer able to do that. Now there can be some slight modification in the standard rate, but they're required to provide those individuals coverage, including persons who may be pregnant. And so I think that amendment has really has proven to help a lot of our people.
Mr. Chairman, through you, and in terms of just the answer so far, I think that there are some specific recommendations that can be put forward to whatever government of the day there is that would cure a lot of these issues, or at least it sounds so in the discourse so far. Is it because the insurers are so powerful as a lobby group that some of these things fall on deaf ears?
Through, through you, Mr. Chairman, I don't know if I have any evidence one way or the other on that matter. But what I can say to you with confidence, that certainly from the department's point of view, and certainly from the Health Insurance Commission board and myself as a superintendent, we have no trouble in pursuing an insurer where it is some violation or there is some infringement in regards to the health insurance legislation. We do not fear them. It's very clear that they're a key stakeholder, but certainly compliance with the legislation as is set out is certainly required by my office.
Would it make your, let me rephrase that. Would your office have additional authority that it could use if you were allowed to do administrative fines instead of having to appeal to, I guess it would be the DPP, to prosecute somebody?
Yes, Mr. Chairman. In 2013, the law was amended to allow some offenses under the legislation to be dealt with administratively. And I have been applying those as superintendent, obviously on behalf of the Health Insurance Commission board. Now, can we add more fines or more offenses that could be fined administratively? I would want to hazard and say yes, because I can say though that when we refer cases, through the Director of Public Prosecutions, let's put it this way: the wheels tend to move slowly, and again that could be with a lot of good reason. But from where I sit as superintendent, when I put forward cases, I have a real person who's made a legitimate complaint, and we would like to see those complaints expedited, because again, in many cases we're talking about uninsured medical expenses, or where there have been deductions from people's salaries. So those type of things, we want to make sure that we send a very strong message that will not be tolerated.
Why is it that you require a non-insured patient permission to report, or that the provider requires the patient's permission to report an uninsured individual to you?
Thank you, Mr. Chairman. I think it's that relationship between the healthcare provider and the patient, and the healthcare provider perhaps not wanting to.
But there's nothing in legislation that says they can't, right?
Absolutely not.
Right,
Yes,
and
absolutely.
it's not. We're not talking here.
And
about,
we encourage it from the
right,
commission.
we're not talking here about a matter that would normally be expected to be covered under patient confidentiality, because there's not a patient yet. They don't get a patient until they get admitted, unless to get the service. And if they turn up and they don't have health insurance, we need to have a mechanism that the health provider who finds that can report that to your office, and you should be able to report who their employee or is as well, if they're not self-employed.
Thank you, Mr. Chairman. I want to agree with you on that matter, because when you look at it from the health insurance point of view, when a policy is terminated, under law, they're required to report that. Again, we have the situations, right, where some healthcare providers do report, but it's on a voluntary basis, and it's very sporadic. In other words, because it's not a requirement, some months they report, other months they don't report it, and from my office, I really don't have any authority to go after them to say, you must report this, on an ongoing basis.
Thank you, Mr. Chairman. Mr. Chairman, through you, I'm not 100% sure that this would fall under your responsibility, but I know of cases where people have worked all their life for a particular company, and as soon as they're retired, they're automatically dropped from the insurance. Is there somewhere we can keep? I mean, when they really need the insurance is when they're being dropped from insurance. What can we do to ensure that these persons, if they're able to continue the payments on the insurance, can continue being insured?
Through you, Mr. Chairman, an excellent question. And I can say to you that this matter has been under review consideration by the Health Insurance Commission Board, probably, I would say probably over at least the past year. And we've come up with perhaps a few recommendations on the way forward. So one of the things that we talked and we felt could probably work, it would mean that you would need to start paying in to the plan while you are working, so that when you reach retirement age, you would have access to that coverage, that medical benefit coverage, through that mechanism. The other thing that we looked at, and in the U.S., I think we're familiar with Medicare, where again they have the system set up where you can get health coverage, for once you retire. The bottom line is that the only other way around that would be for us to actually introduce a national plan where there is, again, contribution by every single person. And again, it would probably be done through some type of an income tax. And it would probably require at least a single provider of, meaning the health insurance cover. And then you could probably set up a number of healthcare providers, meaning a network, once they are agreeing to accept that level of remuneration for services provided, that they could be part of that network to provide these benefits and services. So we have looked, like I said, at 3 possible scenarios. And it seems to me that the way forward is that we're going to have to find some way to have a direct contribution into a fund, whether we're looking at a fund that would be set aside just for senior citizens upon their retirement, so that they could then, that would be automatically covering their healthcare needs, or whether we're looking on a more national plan where it would cover everybody regardless of your age.
But wouldn't it be a simpler solution to just simply say and put in the regulations that a person's health insurance coverage cannot be canceled as long as they pay the premium?
So the
Because
question,
then it would become a retirement benefit, and if you continue to pay the premium to the insurance company, they have to cover you. Because what we're doing now is we're allowing people who, as Captain Eugene said, have paid health insurance for 20, 30 years, 40 years with these insurance companies, but when they get to the magical number 60, the insurance companies say, we're not covering you no more. If the law simply said you cannot cancel a person's insurance as long as they pay the premium, then you wouldn't have to get into all of these other machinations of,
thank you, Mr. Chairman.
That's what the 1991 health insurance law says,
Yes. Thank you, Mr. Chairman. I think, yes, that's a keen observation. However, I think we have 2 potential issues with that. If we are aware that the health insurance coverage is driven through the employer. So the employer pays the premium for the employee, and then they, take it back out of their salaries or other, remunerations. The second part of the challenge is that when a person reaches retirement age, a lot of times now we find that those individuals are not able to afford the cost of continuing to pay that premium. So even if the employer were willing to make the coverage available to them through their plan, the employee is not able to afford the premium payment. So that would be a potential.
Unless it was part of their retirement package from their employer, which is what I'm suggesting, in that they stay in a group. Because the problem would be in over 60, if you're not in a group that has a huge percentage of healthy young people in it, your premiums are going to go through the roof.
Yes.
So what I'm suggesting is that we keep them in that group, and their premiums should not increase.
So, Mr. Chairman, then I think what we're saying is that while you're working, you pay into that so that when you retire, you don't automatically fall off. And as it is right now,
But I would argue that that's what I'm doing now.
well,
Because what I'm doing, I mean, I'm not set up a separate fund, but the premium that I am paying, right, is covering me as health insurance, and it is the global group that I am paying, right, and it has that actuarial demographic calculation in it. So I am not at age 20, I am not paying a smaller premium than I'm paying at age 60 in the same company. We're all paying the same premium. Only difference is that between 25 and 50, the utilization rate is very, very small. So my argument is that I have contributed to that fund all these years because the insurance company has made profit on me every year. We can't, if we're saying that we can do that and then we have to make an additional payment into some fund when I'm retired, I think it's onerous on the consumer.
Mr. Chairman, I take the point that you're making, but
Because
certainly
if each one of us, on an annual basis, which we're entitled to, asks the insurer to give us a clean history, right? You would find most between that age group, the majority of the years that you work and pay that insurance, your premiums that you pay in vastly exceed your claims on an individual basis.
on the individual basis, but
Until you get up to 50, 60.
sure.
Right?
But even while
If you're going to do that, then I want a cheaper premium based on my risk factor. Because we're enforcing the risk factor on 55 and over, by increasing the premium. But we're not admitting that the young person is a much lower risk and their premium should be less.
Well, for the standard health insurance contract, as you know, the commission does regulate the premium for that. So we have actuaries that actually determine what the premium rate should be, and that is what is enforced.
And that's how and you will agree that they're based on the fact that at the top end, you're going to have higher utilization than you're going to have down here, but the premium can be kept at this level because these people are paying way beyond what they're using. Mm-hmm. For those who are using more beyond what they're paying. Follow up.
Thank you, Mr. Chairman. The way I see it, Mr. Chairman, through you to Mr. Conley, the insurance companies act as a cartel. I mean, whatever one does, you can't go from one to the other and think you're going to get in a difference. It's all the same, and it's totally unfair to the working man that the insurance companies can collect his premiums for 40 years, and then when he gets 60, even though he's able to continue, they paying the premiums. They because you're that retirement age, they drop you because now you're becoming a higher risk. But I agree with the chairman that between the ages of 25 and 50, there are very, very few people who make any significant claims, or unless, of course, it's a car accident or an accident, or they may get down with cancer or something like that. But that's few and far apart compared to the ones who are not claiming anything, and the amount of premiums that the insurance companies are collecting. I agree. premiums they pay far, far exceed the claims that they make. And there has to be some justification somewhere, somehow, that will allow the guy, when he needs to have insurance, the person when they need to have insurance, to be able to have it. Whatever legislation that needs to come into effect, I think it's on our shoulders, the legislators, to make sure that this has to change. It just can't continue like this. It's just, I don't know how it's gotten this far for so long without something being done about it. And I certainly will make every effort to have it changed, I can assure you.
Through you, Mr. Chairman, again, as I said earlier, I totally agree with you that this is a significant concern for the Health Insurance Commission. We see, obviously, the concerns and the issues and the complaints coming in from persons who were not able to continue their health insurance cover at an age when they need it most. So I would certainly endorse any initiative for us to try and correct this issue, this problem.
Mr. Chairman, through you to Mr. Connolly, in terms of some of the testimony we got again a few weeks ago, I guess the CEO of Cynical kind of succinctly put it this way when I put it to him. It seems like the private insurers are allowed to insure only the healthy, and the government and Cynical take up everybody else. Is that a statement that you would echo, or can you provide kind of a lay of the land in terms of the statistics and other things that you gather through your office and the various boards that feed into your office?
Thank you very much, Mr. Chairman. Through you, I can say that while that may be a perception, I don't think it's the reality. Cynical is certainly not the largest insurer at this point in time. Based on the last report that I received in January, I think Cynical has approximately 15,000 insured persons. There is at least another insurer that has 20 plus insured persons. In addition to that, in regards to Cynical carrying all of the high-risk persons, again, from my office, I don't see really where that is actually accurate. We have made amendments to the legislation which required all approved insurers to accept providing coverage for all individuals, regardless of their age and their medical condition. And I can say to you, let's use again, for example, the issue of the high-risk medical applications. We see that those applications are certainly not just going to Cynical, that are coming from Cynical, they're coming from other approved insurers, and certainly including pregnancies, etc. And I would say that if you had asked me this in 2012, I would probably be more, more leaning towards that being a fact. But where we are in 2017, based on the data and statistics that I'm seeing, I think the amendments in 2013 has made a huge difference.
Thank you for that. And just one last question from me in terms of, again, your role as an advisor to the ministry and the minister. Has it ever been a consideration to set up captive for the Cayman Islands government health insurance kind of claims.
From the point of view of, through you, Mr. Chairman, could I ask for additional clarification? Would it be from malpractice insurance or from?
For malpractice as well in over there, but I'm talking about in terms of overall claims versus what we pay out per annum on health insurance for indigents, elderly, etc. Has there ever been any thought of self-insuring and seeing that some of those, if some of that money isn't used in a budget year, it comes back to government?
Through you, Mr. Chairman, the answer is yes. That was, as a matter of fact, when we look at Cineco, I mean, the whole, I think, the Cineco was driven, the creation of Cineco was driven by, at some point in time, that there would be what we refer to as an ASO, where those groups would be properly identified, their demographics and risks, etc., and all that would have been sorted out, and we would have established a plan of coverage for them based on the group itself. In addition to that, we had envisioned that those groups would have been adequately managed, meaning that we would know exactly what level of facilities and care would be provided to those individuals, and that there would be follow-up to ensure that those patients and insured persons were closely monitored. Because if you look, for example, at the group right now that we call the medical indigent, based on the last information that I saw, we're averaging close to $2 million a month, and it seems to me, and that is and the number of persons now on that medical indigent list is just around 1,300 persons. So it seems to me that that is a group that we could easily look at identifying, setting up the parameters, and having coverage, even if we had to put in some stop loss coverage, meaning that if there was a catastrophic event that exceeded, let's say, $200,000 or $250,000, that you would have stop loss coverage that would immediately kick in. It seems to me that initially I am certain that it would probably cost a lot to provide that group of coverage, but I believe that in a very short period of time, meaning 3 to 5 years, that it would certainly pay off if we managed it properly.
Yeah, Mr. Chairman, through you, and thank you for that, because again, when you go to these captive health insurance conferences, I'm sure you've been to a few here, you hear that Cayman is the mecca for this. We've got the expertise here, we've got the consultants, the administrators, all the above, and it has occurred to me, especially in the last 4 years, that there is real merit in utilizing those sorts of vehicles, and if it means tweaking Cineco or whatever to do it, because like you said, in not a very long period of time after that initial setup cost, the country is the beneficiary, the people are the beneficiaries, and so it doesn't even take a long-term vision. It takes even if you call it a medium term, I mean, if you're talking political cycles, it's still worth at least going through the exercise, crunching the numbers, and considering something of that nature. Thank you for that.
No more questions? Okay, well, Mr. Connolly and Ms. Joseph. Yeah, Lawson Joseph. Thank you very much for coming and participating in the process, and you're free to go.
Thank you very much, sir. And,
Thank you, sir.
And I just want to add, Mr. Chairman, that obviously I think the report provided by the Auditor General's office is quite timely, and certainly from where I sit, I see a number of recommendations, etc., is extremely constructive, and we are certainly going to be making some changes. For example, the reporting framework, I've already started discussions with the chief officer in regards to how we can, certainly make our reports much more meaningful, including, trend analysis, etc. So again, thank you for this opportunity.
Just one mark. Yeah, just one matter for the committee. What is Friday morning, this Friday morning, 10 o'clock, okay to look at the draft report? Yeah. Okay. So we'll reconvene 10 o'clock Friday morning, the 17th, to look at the draft report because we got to get it read and submitted before the 22nd. Thank you all very much.